Hello and welcome to CHD Wise, an education series for patients and families. My name is Becca Kalivas and I am the Education Director at Conquering CHD. This event is being pre-recorded and the recording is stored at conqueringchd.org. In today's episode, we welcome panelists from Cincinnati Children's Hospital Medical Center, Children's Wisconsin, and Seattle Children's Hospital for an open discussion as we explore feeding and nutrition considerations for patients with CHD. This episode of CHD Wise has been made possible through our partnership with Berlacta Bioscience. Together, we've collaborated to connect patients and families to connect them to important research. We've worked together for several years, both during the pandemic and pre-pandemic, educating patients and families about the importance of human breast milk. They are currently in clinical trials researching an exclusive human milk diet for infants with single ventricle physiology, which Megan will talk about more in a little bit. Their foundation helped us fund our COVID-related research program last year called Inform CHD, which has been instrumental in researching the effects of COVID in the CHD population. And they've also been consistent supporters of our annual legislative advocacy conference in Washington, D.C., and our advocacy efforts throughout the year. We'd like to say a special thank you to Prolacta for your continued support of our education and research programming. And now I'd love to introduce our expert panelists for this webinar. Megan Horsley is a pediatric dietitian at Cincinnati Children's Hospital Medical Center. Julie Lavoie is director of the enteral feeding program and cardiac quality and outcomes at Children's Wisconsin, and Jen Fridgen is a physical therapist working with the feeding and development in single ventricle patients at Seattle Children's. Welcome everyone, and thank you for joining us. I would love it if each of you would take a few moments to just tell us a little bit more about yourselves and your background in CHD care. Megan, we'll start with you.
Great. Thank you, Becca. What a nice introduction and welcome. And thank you to all our listeners. I think you'll really enjoy our conversation today and hopefully be able to take away from today's discussion. So with that, my name is Megan Horsley. Again, I am a registered dietitian at Cincinnati Children's Hospital. I spend most of my time at the bedside in the cardiac ICU. But enjoy doing nutrition research and quality improvement work. I've been a dietitian here at Children's going on 15 years, but I'm also a heart mom for 17 years, going on 18 years. I work very closely with some of the cardiac networks that are available to our population, such as NPC QIC, Action, which is devoted and focused on heart failure and ventricular assist devices, as well as the PC4 Pediatric Cardiology Consortium Network, all focused on improving the care for our cardiac patients. So I'm happy to be here.
Hey there, my name is Dr. Julie Lavoie. I'm also thrilled to be here. I've had the pleasure of working with Megan for much of that last 15 years, though I'm at a different center. We met through NPC QIC several years ago. And really my drive to pursue a career in clinical medicine and translational research stems from 15 years of service at Children's Wisconsin. And I found that a leadership position in this arena has really complemented my clinical background as a pediatric acute care nurse practitioner, a nurse researcher, and a dietitian. Improving nutritional care for children with congenital heart disease has always been my passion. And I really feel strongly that collaborative patient-centered medicine is the best way to achieve optimal outcomes for these patients. So I'm, again, just honored to be here today and excited about the conversation we're about to have. So thank you.
Hi, thanks for having me as part of this webinar. I am also very excited to have a discussion about this topic. My name is Jen Fridgen, and I'm a physical therapist with over 20 years of experience. I have spent my last 15 years as a member of the infant feeding team at Seattle Children's Hospital. I work closely with infants with complex congenital heart disease, and I specialize in the single ventricle population. I get to work really closely with infants and their families throughout the first year of life. I often get to meet families during the prenatal period, and I follow the infant all the way through their journey of preoperative feeding, their first feedings after their surgical intervention, and hopefully through to a time without a feeding tube. I work hard to establish positive oral feeding experiences and to maximize each baby's feeding and developmental abilities.
Great. Thank you guys for those introductions, and thank you again for joining us. As we start the discussion, I wanted to highlight the fact that you're all from different centers with different professional backgrounds. However, it really seems like you ultimately all have the same goal in mind as you interact with families. I was wondering if you'd each briefly share in your minds, what is that goal? Or perhaps you have a patient story you'd like to share that showcases the importance of this topic.
I'll go ahead and start. When you mentioned briefly, it may not be so brief, because as I was reflecting on these questions, so much has happened. But I'll start with personally sharing what my goal was when I started. Again, as I mentioned earlier, I'm a heart mom, and I started at Children's about 2 years after I had experienced being a heart mom for the first time. And so my goal at that time was simply just to create a better experience for the person who came after me. As you may imagine, I had a lot of ups and downs myself as a heart mom through the process and the flow of the care. And so that was my initial goal. And I knew I wanted to make it better for the next person and all those persons behind me. I experienced both big and small things, like just not being able to feed your child right after you deliver your child, to emergent surgery, open chest and ECMO, having a baby that's open chest and an ECMO. I got to experience with her all the different forms of feeding, whether it's IV nutrition, feeding tube. I was that mom that actually put the feeding tube in the first night that we got discharged in the wrong pipe. So, from intending to want to provide breast milk for the first year of my child's life, to now I had to pump for the first year of life, not actually breastfeed, to also having experience with a chylothorax as a complication of cardiac surgery, multiple feeding intolerance concerns. So this is really where my personal goal stemmed, was to make it better. There had to be a better way for nutritional advances in the care of this population. And at that time, there wasn't ventricular assist devices. There wasn't, PD catheters being utilized. There was still a lot unknown. We've made a lot of advances in the last 15 years in the cardiac care. And I knew I wanted to be a part of those advances. And when you're a parent, as a heart mom, you're in that fight or flight mode, especially around an emergent surgery situation, or, your kiddo is going to have surgery. That's your goal, is just to keep that child alive to the best of your ability. And so even though survival is out of your control. So this was also a way for me to feel like I was giving back to all those people that saved my daughter's life. But of course, over time, and as my child has grown up, my goals have certainly continued to evolve. It's always still that simple, to make it better for the next person, but it's also to be a leader in the nutritional care for these babies, and think outside of the box and prescribe these innovative nutritional things that we may not have ever thought of, or to use to partner with different parents and partner with different providers, and really figure out what is the best nutritional management for this patient population. And so that's kind of how my goal currently is evolving, is just continuing to think outside the box and hear from parents what it is that they think needs to improve, and partner and improve with them. I think also that the body is just such a fascinating thing. And so I always try to think as simply, but also big picture. What is it that the body needs most? And a lot of the answer is around nutrition, and so that helps survival. And it's amazing. I think sometimes we don't think of it as such a vital thing, but it really is a vital thing to not just survival, but growth, development, everything. So that's kind of a brief synopsis, as much as brief I can make it, to review my goal for these kids and my work in these kids, with these kids.
Megan, I think that was outstanding, and I have always respected and appreciated your point of view, and I think you just said it really eloquently. I can speak a little bit about my background and my passion. I am not a heart mom, so I'm not going to pretend to know what that's like. I feel like I've helped many heart moms over the years, and my passion really lies there. I started as a dietitian in the cardiac ICU. That was my kind of first out of school career choice. And over the years, I just felt like I wanted to do more. I started having opinions about when kids should be weaned on oxygen and what an IO ratio was to put someone on ECMO, and I started to speak up more during rounds. And I felt like, okay, it's time to go back to school and start learning other skill sets. And my passion is always going to be nutrition and congenital heart disease. But what I've been able to do is kind of advance my academic career a little bit, to really be able to help kids in a variety of ways. And so that's the reason that it was all of the kids, all the moms that are going to watch this video and all of the kids I've taken care of over the years really inspired me to just learn more, get smarter, and help more people. So that kind of led to 3 master's degrees and a PhD. And I still feel like I don't know everything I need to know. But I feel like research and quality work can help populations of these kids. So I kind of moved from helping individuals. I still get to do that sometimes, but not as often as I'd like, to really helping the population of pediatric patients with congenital heart disease through a nutrition lens. And so something we started, my doctoral work was really in starting an enteral feeding program at Children's Wisconsin. And certainly I hope we can do that at other centers. There's a device called a bridle. And so much of my research is surrounding that. Not all pediatric centers use it, and certainly not all pediatric centers have to use it, but it's merely just a securement device that helps engage the nasogastric tube and create it securely in the nose of these babies. Not every patient is a candidate for it, but it's just something we found that allows infants to go home earlier and work on feeding at home with some support. It by no means cancels out oral feeds. I think we're going to talk a lot about that today. Either does a G-tube, whatever route we need to go is okay, and we're here to support you. And I really feel like my passion is also transparency and outcomes and advocacy for these families. So what do families need? Every family might need something different, but I think if we're aware of that and we can kind of stand next to these families and advocate for them, whether it's on rounds or whether it's through a forum like this, whatever it is, just know that there's a fair amount of us out there that are really here to help and advocate for your child as we kind of go through this difficult journey together. So again, happy to be here. Thank you.
I love both of those stories and experiences. You guys are both so amazing. I feel really lucky to be a part of this group. When I started working at Seattle Children's 15 years ago, I really started diving deeper into feeding, but mostly as a generalist. And so I was going around throughout the hospital and really learning and understanding feeding for babies with all sorts of feeding difficulties. And as I was learning more about the cardiac population, I was trained in a way where it was just that kids with heart defects have trouble eating. They don't usually get to full feeding. They wind up with G-tubes, and they're not a dynamic sort of population that needs a lot of support. Like, they're just in general not great eaters. And as I worked with more and more babies and families, I just found that that was absolutely not true. I think this population is incredibly dynamic. The babies change so quickly. The feeding plans need to change in the same manner that the baby is changing. And so a baby who may be able to fully orally feed at one point, a month later will be struggling and on continuous drip feeds by ND. And so my role and passion is to support the families and the babies where they're at. We want to maximize what we can, but we need to deal with what's going on medically as well. And so educating the family about how things are going to be changing, providing support and positive experiences as much as I can, and really taking them through the journey and holding their story and advocating to the team for whatever we can do to give the family what they really want, which is bonding with their baby, feeding their baby, and connecting, and ultimately getting off of a feeding tube if it's possible. So I can think about a baby that I worked with recently named Dawson, who struggled a lot after his Norwood. He was very sick. He ended up with a complication of a left focal fold paresis or paralysis, and that did impact his swallowing safety. So after his Norwood, he was able to only feed minimal amounts of breast milk by mouth before he had fatigue-related changes in aspiration when he was swallowing. He initially really engaged with feeding, and it was something that his mom loved doing with him, his whole family. As he got closer to his second stage surgery, his heart failure symptoms worsened, and he really lost all interest in feeding. He became very refluxy, very orally averse. Sometimes even just looking at a pacifier would make him gag. And his mom was heartbroken and had this time where she was able to do some feeding. And certainly in the pre-op period, she got to breastfeed, and Dawson was a beautiful oral feeder. So she held on to those memories and just was very sad about how things had been. After his second stage surgery, he was much more stable. We worked closely with our otolaryngology team, and Dawson had an injection on his vocal fold that positively impacted his ability to swallow. He was now able to adequately protect his airway, but he still had all of those oral hypersensitivity behaviors. So the long relationship that I had built with his mom and his family allowed me to help guide them through hunger-based tube weaning. And we worked closely with cardiologists and gradually cut back on what Dawson was getting through his tube as we were reestablishing his oral feeding abilities. And he was able to wean from his tube, expand his feeding repertoire. His mom still sends me pictures of him sitting in a high chair with his family, and they are enjoying a family meal. And it means so much to them. And it really is what drives me to get up and go to work every day and work as hard as I can for these families.
Thank you for sharing all of that. All three of those stories share such a different perspective, but again, with that same common goal. And I think it's so important for parents and families to know that there is that common goal between patients and families and their care team about supporting their child's feeding and growth and development. We often see discussions on our social media or in various online support groups about a different type of goal when it comes to feeding in kids with CHD. The general feeling is that it seems like there's a lot of focus on goal weights or goal feeding amounts by the care teams. I was wondering if each of you would speak a little bit about why are growth and weight gain so important for kids with CHD, and why is that such a focus of the care team?
Julie, do you want to start, or do you want me to start?
I can start. I was going to make a comment. This kind of bridges off what Jen was saying. I think 30 years ago, the teams were really just trying to achieve survival and avoid mortality in this population. And so the landscape has really changed, even, since all of us have been in practice, and we're there, like these babies live, which is fabulous and should not be discounted. But now our focus has moved more to the next thing, which is quality of life, growth, nutrition. And in all the years I've been practicing, families really seem to bond with dietitians and feeding specialists because it's the thing that they can do. As a mom, I recognize that. And I think that is something that families can understand. It's not Latin. It's something that's really innate to being part of a family, is you want to feed your baby. And I think that when I started in practice, it was common and infuriating for me to hear on rounds, well, similar to Jen's experience, that's a heart kid, they're just not going to grow. And it honestly just made me angry and made me want to prove everybody wrong, that no, these kids don't need a special growth chart. They might need specialized nutrition, and they need a feeding specialist and a dietitian and advocacy and a team, but it is not true that they will not grow. Are there growth difficulties? Yes. Why do we want these babies to grow? So that they can thrive, so that we can get them to their next surgery. Often there are weight requirements, so this is why we focus on it. There's a fair amount of research that supports the kind of growth and development is tied to successful outcomes. So we know if volume drops, if weight's dropping, there's something going on and we need to pay closer attention. It's not always a saturation or something really notable that changes when things are going south. It can be small things, like a sudden turn in the amount of volume that a baby's taking in. That's concerning and something we want to watch for, especially in the interstage period for our single ventricle patients. And so we've learned through lots of years of experience and outcomes that didn't go so well, we now know for future generations that these are things we need to pay very close attention to, and that these babies can grow. We've proved that at countless centers across the nation, time and time again, and they are thriving. I know Becca has some stories to share about a thriving child, and I think those are the stories we live to hear about. So it is not true that these babies can't grow. Is growth difficult? It can be, but it's not impossible. Is it important? It's really important for the medical outcomes, for the mortality outcomes, the morbidity outcomes. For even brain growth and development, reaching milestones. Nutrition matters. Clearly, you're speaking to a biased audience, but there's research to support our claims that nutrition matters. So I'll stop there and let Megan fill in the blanks, but that's my 2 cents.
It's so funny because this is why I love working with you, because we think a lot alike, obviously. And I literally wrote, the number one comment I get from parents is that, heart kids should have their own growth charts. Well, they don't grow the same as normal kids, but we certainly have shown in literature that we can get these kiddos to grow. And I won't repeat everything you said, but I'll add to it that even how we assess nutrition has changed and it continues to evolve. We no longer talk about failure to thrive. We now classify nutritional status as one being nourished versus malnourished, and there's different degrees of malnutrition. So yes, weight gain is important, and growth is so hyper focus in this population, and that's because growing means thriving, and lack of malnutrition, if you will. The more nourished, the less complications we're going to have. And it's so true. I am reminded of this on a daily basis. If there's a patient that's malnourished going into a heart transplant, there will more than likely be complications of that malnutrition post-operatively that you may not have expected, but you can expect when you have a malnourished patient going into cardiac surgery that there's likely going to be some type of complication or delay, if you will, in healing. And I've seen this daily in my practice, and it just is a reminder of why, I am in a good spot and why I do what I do. So as I mentioned, that nutrition assessment is evolving. We now do other things. We have other skill sets that we have added on to really assess one's nutrition. We do mid-upper arm circumferences. We do body analysis. We measure and look for frailty assessments, like using hand grip strengths, dynamometers. I can never say that word correctly, but there's lots of different ways that we really assess nutrition. Historically, as Julie has mentioned, the surgeon a lot of times puts a weight that he or she would like that child to be at when they're going for surgery. So in the past, there was like, they need to be 5 kilos or they need to be 15 kilos. But over time, we have continued to evolve in how we even talk about one's nutritional status. There's certainly a hyper focus on that going into surgery. And so I think that's why there is so much push on that. Even a non-cardiac kid, right? You take your normal growing child to the pediatrician. If they're not gaining, there's gonna be a hyper focus on that. So it's across the board, targeted benchmarks, if you will, that we still need to kind of utilize in our practice and go off of, because we know it's a positive measure of thriving. And certainly, and a lot of our heart babies or patients, if you will tolerate lower thresholds of those weight gain per day or linear growth per day. But certainly we all want to try to achieve to the standard that we can. And we do know that, these kids can grow, but we do have to often individualize the plan and utilize multiple resources, if you will, in order to really help improve their nutritional status. So I would love to get out of that thought process of like just the weight gain pressure, if you will, or like you have to have this much grams per day, and really focus on the nutrition as a whole, the body as a whole, and is this patient look nourished? And so that we set them up for success. So
I think that is such an important idea, Megan. We're all saying the same thing, and these families that are so invested in their little babies and getting them to surgery with a weight in mind. They need to be 5 kilos. Mom hears that, and she is going to do everything in her power to get there. We need to achieve that weight. We can go for surgery. So how does that then impact feeding? The mom may be pushing the baby too hard, creating sort of negative experiences, feeding for an hour and a half at a time in order to get a certain volume that might be needed for each feeding, and having that ending up backfiring with the baby burning too many calories and ending up losing weight. Families will come in with these incredible spreadsheets of like how long the baby ate, how many milliliters they took, and just that hyper focus on how much weight is the baby gaining. On our interstage babies, families are sending in daily weights. And so it is a way that it just reinforces that focus on weight gain. And they know they're going to get a call if weight is stagnant for a day or two, and things are going to be rearranged. And so I feel like a feeding therapist needs to be a part of the team to really help educate families on just how feeding is going to differ throughout their journey, and how they can maintain intact oral skills for future stability, and really how that will translate for them. Yeah.
I just want to make a quick comment. I think, Jen, you really nailed it by saying the level of involvement that's required from these families. And I cannot imagine the amount of stress that they're under. I've done interstage clinic before and just taken a moment to say to a mom, how are you doing really? And usually they cry. that would say 9 times out of 10 they cry, because it's so intense. And how can you not feel responsible? But I want to take a moment to say, you're not entirely responsible. Lean on your team. Let us advocate for you. It is not your fault if your child is not gaining the appropriate amount of grams. We kind of explained why we are hypervigilant about it, and it is important, and we can't take that away. Nutrition status matters, but it's not all on your shoulders, and you could do everything right. I would say nearly all of my patients do everything right. And sometimes their child has difficulty growing, or lack of interest, or vocal cord paralysis, or they get tired out, or whatever it is. And so there are nutrition supplements that are helpful. Does that work every time? It doesn't. And so it really is, this is where science meets art. And sometimes nutrition is more of an art than a science. Feeding is more of an art than a science. Sometimes we know a lot, but we don't know everything. And I think it's important to just partner with your providers, with your, speech therapists, dietitians, everyone on the team. There's a lot of great folks across the nation, and just know that we're there to listen. I think that's just as important a piece of our job as everything else, because it's hard. We know it's hard. We don't send you home with these crazy plans and think it's going to be easy, you've got this, and everything's going to go smoothly. Like, we know that it's not. And so I think that's an important sentiment.
Yeah. And I would add on, one of the things that Jen has said now twice is educate. It's, we've kind of joked of this in the past, but we would love to be able to provide like prenatal classes for moms on how to just feed your baby normally, and then to have like a better baseline, right, of understanding on just how to feed your child, because you really don't get this in the prenatal phase unless you're seeking it yourselves, or you have experience, with other children, or babysitting, if you will, whatnot. But there is no right one way to do this. And so I think education is also key if you have concerns about the goals that have been discussed for your child, or first of all, make sure you know the goals and the criteria, set forth by your team for your child. But certainly if you don't understand them, then that creates the opportunity for just more engaging and education around, around that topic. And so since Jen has reminded me now twice that it's important that that's a huge part of that partnership, is just education and making sure everybody's on the same page of the goals, because, specific goals, if you will.
Yeah, Megan, I love that. And I think having goals and transparent goals is really important. And I just take it one little step further to say that we need to ask what the family's goals are too, and understand, is breastfeeding very important for this family? And if it is, how can we incorporate that? Some moms say, I just want to provide breast milk. For me, it is just fine if it comes in a bottle or by a tube, and we can respect that. But the moms who really want that breastfeeding experience, just understanding the family's goals as well, beyond just, of course, like, I don't want a feeding tube.
Absolutely agree.
I was going to say the mode of nutrition as well. So I've often said to families, when I say the word G-tube, how do you feel? And sometimes I've had families say, put in the G-tube. Like, I am over this nasogastric stress of trying this orally and trying this through a tube that keeps coming out and all of that. And I've had other families say, I will do anything to avoid a G-tube. And so there's opposite ends of the spectrum, and knowing where a family is at that can help us support you through the journey of whatever your goals are.
Since you brought that up, sometimes meeting the nutritional needs of kids with CHD does involve the placement of an NG tube or a gastric tube. We recently had an email from a parent who asked, my child has a feeding tube, so how do we now assess their readiness to wean from that tube back to oral feeding?
Want to start, Jen?
One of us
Yeah,
can
I
start.
think this is something that I have gotten to work with through our Heart Center at Seattle Children's, but also through NPCQIC. A few years ago, we created a tube weaning readiness checklist. And it's something that involves all of the members of the team. It requires a cardiologist to speak to the stability and health of the heart. We need a dietitian involved throughout the process to assess the level of nourishment or malnourishment if it's present. And then we have the feeding therapist who's going to be working on the mode of how the baby is taking the food in. And so it's reaching that cardiac stability and a point of nourishment where it's possible for the baby to safely have stagnant weight or even a slight decrease in weight. And so it's not determined by one person, but really by the team. Any part I missed on that?
No, I think the highlight of that is really it's a multidisciplinary approach.
Mm-hmm.
It's intense, but that, we heard from families that there was a lot of feelings like once their kid made it through surgery, got discharged from the hospital, then there was very little resources for them to further get their child to eating by mouth, all by mouth again. And so throughout the NPCQIC collaborative, a few centers championed and heard these parents and brought these parents onto this project, if you will, on how we can develop a tube weaning process, if you will, that could be disseminated across all centers. Because we had information where parents were seeking, additional services for helping them get their child off their feeding tube, but spending a lot of money, potentially never seeing the team that was conducting the wean, or not having a understanding of the background of the cardiac, if you will, procedures. And so we felt as a community of 50 some centers, maybe even 60 now across the nation, that this was a voice that needed to be heard, and we needed to provide for our families some guidance on how we wean children off their feeding tubes once they are ready to progress in that nature. And so, as Jen mentioned, they have to have some cardiac clearance, if you will. That's a huge piece of it. And as often, a lot of our patients are still on medications around cardiac, like diuretics. And so once that's established, and once the swallowing safety has been established, and the nutritional status has been confirmed as nourished, then you can really start to focus on creating these positive oral experiences, provoke hunger. As Jen mentioned, we cut the feeds in order to provoke hunger, and then being intensely monitored throughout the process. So there are centers that are starting to really take this type of checklist and roll with it and build their programs to offer for their families. So an interesting side note is, which you'll see later, and it'll be attached to this webinar, but as Jen mentioned, her and I worked on the tube weaning checklist and a literature review around tube weaning. And we were able to publish a paper about this. And I recently had a father who was not ever part of my center, and I had never met this family before, but actually contacted me because my name was on the paper, and they wanted some guidance on whether or not, how they could get this for their child. How could they get help to wean their child off of a tube? So parents look for the research, and we've started to publish the research, and we know it's a possibility for our patients to be 100% orally fed. but it does take a team and it does take close monitoring.
I think that's really well said. I think that importantly, for any child who is on a tube, before you get to that space where you feel like I'm going to talk about tube weaning, I want to remind folks that it's really important to advocate for concurrent oral intake, if at all possible.
Yeah.
So just because you have a G tube, this is a common question we get, doesn't mean you can't orally eat. If you can and ask that question frequently, then do so, and do so safely, and use your feeding guidelines, of course, but it's definitely not an either or. It's an and in many cases. Certainly there's cases in which it's not safe to orally feed, and that's a separate issue. But if you are safe to orally feed, even with a tube, we recommend it, even with a nasogastric tube, but keep working on oral intake. And I think when, these ladies said it so eloquently, is when there is a time, if there's a time to do tube weaning, it's important to do it with a team. I think that, we heard parents and they were going to do this, whether or not we were going along for the ride. So I feel like, does it make some of us nervous? Yes, it does. I think it does depend on your cardiac history. It depends on what medications you're on. Remember that nutrition isn't just calories, it's volume. So if you are in a case where you shouldn't become hypovolemic or have kind of low volumes in your body, I don't know how better to explain that.
Perfect.
that can be dangerous too. And so it's not just about the calories, it's also about the fluid volume. And so these are important questions that your medical team can help you answer and kind of walk through the process with you. And so can it be done? It can. Is every person the right candidate? No. So it's important to work with your teams on what makes sense. And then if your child has a tube, which many cardiac patients do, doesn't mean they can't eat orally. And I think that being that parent advocate or finding a feeding specialist to help you advocate for your child. I've had many families, they're afraid once that G tube gets in, they will not be asked about oral intake anymore, and they won't be able to see the feeding specialist and keep working on it. And that's just not true. Sometimes it requires some advocacy, but it's a really important piece of the journey.
Thank you for sharing that. Sorry, go ahead.
Emphasized, sorry, Becca. Just one more quick thing to add. I think we've emphasized the importance of a multidisciplinary team and really following along with the cardiologist closely. But every tube weaning or hunger-based tube weaning plan is different, and it is unique to that child. And so there is no recipe, if you will, or very standard process. There are themes and there are certain components that remain the same for almost all of the babies who are going to be eligible to wean from a tube, but every plan and program is individualized.
Yeah, I think that's a great point. Go ahead, Megan.
I was gonna say, I gotta add one more thing that hasn't been said yet, but it's very important that we say it, is that we've also emphasized that once a feeding tube goes in, the minute it goes in, we should be having those discussions on how we're going to get it out. And whether that's when the baby child is 2 days old or 2 months old, we want to encourage parents to have those conversations and ask what would be the criteria for removal. And I know I'm trying to be more aware and do that in my own daily practice, but really strongly encourage parents, as soon as that tube goes in, okay, how are we going to get it out? What's the criteria for removal?
And I think asking what resources are available at your center right from the get-go are important. Again, attached as part of the resources to this webinar, we started an enteral feeding program at Children's Wisconsin, and it is not unique to cardiac patients. It's for anyone who would benefit. And our goal is to, as Megan alluded to, and as Jen alluded to, educate. So our enteral feeding team wants to meet with the family before any tube ever goes in, if humanly possible. And we want to stay with that family until they've reached certain stability. Does that mean every tube comes out? No, some kids have tubes for years, and that's completely fine. If they're really stable, family feels comfortable, they're well educated, they can replace that G tube on their own independently. We can kind of let them fly and see their regular provider. But if there's any education needs, feeding changes. If things are transient and kind of moving quickly, we like to stay involved with the family, whether they're inpatient, outpatient, or at home, just to really hold their hand and walk them through the process, because we never want to assume that our job is done once we put the tube in, because that's really where it starts.
I think that's really great points to add for families to know that it's okay to advocate, kind of what to advocate for, when to start advocating. It's all really complicated for parents. You guys alluded to a little bit the research aspect of this. So I want to touch quickly because it seems like there's always something new coming up, new research being done. Megan, pretty briefly, because we're really short on time, but would you just share a little bit about some of the advances or the current research happening with regarding to feeding and nutrition for patients with CHD?
Absolutely. So most recently, I will state that there was recently a randomized control trial to evaluate the growth velocity and clinical outcomes of infants with single ventricle physiology that were fed an exclusively human milk diet. And also that included early nutritional fortification sooner after surgery than most standard hospitals. Though this was a multi-centered study, it included 10 centers, and it took place from 2016 to 2020, I'm sorry. It was an industry-sponsored study from Prolacta, and it is in the works for being published in a manuscript. So that should hopefully be out early next year. And there was an abstract that was given recently in September at the Pediatric Cardiac Intensive Care Society meeting. So that's probably one of the most latest hot topics of nutritional research. In addition, there's a lot of quality improvement work going on. We mentioned NPCQIC, which stands for National Quality Improvement Collaborative, and I apologize if I didn't mention that earlier, but it's an accumulation of over 50 centers across the nation working to just improve the care in single ventricle physiology. And so there is a pre-op feeding project that's going on through that. I know Jen can provide more resource for that. Since we're running short on time, I won't go into that, as well as a chylothorax algorithm that is currently in the works through the PC4 group. So there's lots of networks. There's about 5 different cardiac networks. They all have joined together under Cardiac Networks United. And so that would be a website that you could go to as parents to learn about all the different projects. But those are the biggest ones. And then recently, there's that tube-wean paper that was published, as mentioned earlier, as well as Julie's enteral bridle publication, which we will have links to all that at the bottom of the webinar notes.
Julie or Jen, anything to add with the research and upcoming advances?
I think the biggest take home from the preoperative oral feeding project is that there are still some centers who are hesitant to feed babies with ductal dependent lesions who are on prostaglandin by mouth before surgical intervention. And a lot of that fear is around necrotizing enterocolitis. And so the project is really education, again, to the cardiac teams that this is not something that happens from preoperative feeding. The incidence of necrotizing enterocolitis is not higher if you feed preoperatively, and the benefits for the family and the baby are so much greater than any risk to the baby. So pre-op oral feeding should be the standard of care. If a baby is medically able to eat by mouth, they should be allowed to.
I'm just going to, again, put in a plug for families to advocate for their child. And I want to explain the difference between a center's culture and evidence-based practice. And those two are not always married. So you may be at a center, like Jen mentioned, who will tell you, we don't pre-op feed, it's dangerous. That could be a culture. And then if you look in the research and you look at the evidence, that's not the case. And so I think asking questions is fine. I think standing on rounds, talking with your cardiologist, talking with your dietitian, feel free to push back. This is your baby's life. This is your baby's growth and nutrition. Ask, do you have a feeding protocol? What does it look like? Will I be allowed to breastfeed? Why not? I know other centers do. Certainly feel free to reach out through Conquering Congenital Heart Disease. There's lots of good resources there if you feel like you're not being advocated for, or you have questions that you feel are not being answered. There is a guided question tool that Conquering CHD has partnered with all of these centers and put out. Children's Wisconsin, Colorado, several other centers now have answered those questions unique to their center. It's not all feeding related, but it definitely helps you advocate for your child and ask some questions that you might not think of when you're in crisis and your baby's in the ICU, or as you're pregnant and preparing for delivery of a child with congenital heart disease. So again, just a reminder that centers may feel very strongly about the way they practice, but that doesn't necessarily mean that they've read all the latest research. It takes us some time to adapt to all the latest things. And so it's important to be a part of these collaboratives and communicate with other centers and work together. And sometimes it takes us a little bit of time to get our act together. So please be patient with whatever center you're at, ask the right questions and push back when you feel like, hey, you know what, I've heard a little bit about evidence-based practice and feeding. I'm hearing that other centers are doing this. Can you help me find some more information to look into that?
I think that's a really great point, is ask those questions. It is okay to ask those questions. That's why the guided questions tool exists, and why many centers have preemptively answered those questions for families. I think we've seen in our discussions today that supporting the feeding and nutrition and development of these patients with CHD truly does take a team. And that team does include parents. It's not the medical team and then family. It's one big care team.
The center of that entire team is the parents, and it has to be.
Yeah,
Yes.
agreed.
So you guys are really in charge, no matter what anybody tells you.
So as we close our discussion, just quickly, how can parents learn more about the different feeding and nutrition options for their kiddo, advocate for their child's nutrition, and then just kind of what advice would you give parents about supporting their child's nutrition?
Ask a
Oh
lot of
gosh. I was
No,
thinking,
it was
Julie,
a lot
you
of
said it.
questions right off the bat.
Yeah, Julie, you said it so well. I don't know if I have much more to add. I think being present is important. I will state that. I think, or having presence, whether it's family members, if, you have to work or something like that. But I do think being present is always ideal, because that's where these conversations happen and can happen right in real time. I can't stress enough just to challenge and ask questions, reach out, do your own literature search as well. We want to grow and learn together and improve the care together. And as Julie alluded to, some of the cultures sometimes can be a barrier to progress. And so really you have to challenge that culture, and you have to really bring that elephant to the forefront in the room, if you will, and really partner with them to improve it or make change. So I don't know if I have much more to add to that.
I think that was well said. Bring papers to rounds, bring questions. If you can't be on rounds, there's so many, especially with COVID, and families have other children and moms are busy. We get that. You can ask for time. Don't feel bad about asking for time. Say, at least, once a day, once every other day, I need an update. Can someone give me a call? I think we're a lot more used to that since COVID. Having kind of virtual touch points with families is definitely feasible. I feel like we have the mechanism for that more than we used to. And just keep asking questions, and don't feel like there's such a thing as a question that's not valid, or there really isn't. We're all learning together. We certainly don't know everything about every child. I always tell every mom that I have the opportunity to care for, you know your baby better than me. So if you're telling me something's not right, this is different, I have a question or concern. We, once we get in the clinic setting, we see them for 20 minutes and you have them all the time. And so I think be proud of that and stand up for yourself and your child and bring your questions. That's what we're there for. And if
Yeah,
you're not getting those answers, if you feel like it's not a good partnership, then find someone else to care for your child, because you deserve that.
I think rounds can be really intimidating for families too, especially if you are at a teaching hospital. There's so many people. Sometimes it's hard to know who is in charge and what role everyone is playing, and the faces and the players change a lot. And as much as possible, be confident in that setting and speak up. It is intimidating, but it really shouldn't be. And if it is really challenging for you to talk with that many people and providers present, ask for one-on-one time at the bedside or request a care conference with your child's key players.
Or tell your nurse, say, I have 5 questions and I can't ask them because it's too tough today. So can you ask these questions? Write them down, take notes, whatever you need to do. But your nurses are there for you. So I feel like you could absolutely, I've been a nurse too in my past. So just put it on your nurse, ask them, say, here's my questions, and you need to be there and stand up for my child today because I'm not feeling it. I'm not going to stand up in front of 30 people and ask questions that I don't really understand. So
I think, as a heart mom to a young single ventricle kiddo, if somebody had told me this information 4 years ago, our feeding picture would have looked very different when he was a baby. So I appreciate you guys encouraging families to advocate and empowering them to have those conversations with their team, even if they're tough conversations to have. So I just wanted to thank you all again for joining us. Super informative presentation. We are going to close out, unfortunately, because we're just out of time. So for the recording of this CHD Wise episode and all of the information we referenced today, please visit us at conqueringchd.org/learn/CHD Wise. For any of the resources mentioned, there will also be a QR code at the end of your screen at the end of the video. Until next time, thank you all, and thank you all again for participating.
thank you all so very much. This was a pleasure. Thank you, Becca, for keeping us in line and on time.
Thank you guys.
All right, take care.